All right, well, good evening and welcome everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckbill and I will be serving as your program facilitator and will present your questions to our panel of experts. This evening, specialists from geriatric medicine will discuss age-friendly care, what it is, the protocols that are in place, outpatient programs, care teams, and more. As we know, seniors have more complex medical needs, and we are here to meet them. Jefferson Health is recognized as a leader in senior health and geriatric medicine through a variety of inpatient and outpatient services, as well as home and community-based programs. We offer comprehensive care and support for seniors and their families. Several Jefferson Health locations have received age-friendly health system designations as established by the Institute for Healthcare Improvement, recognizing evidence-based practices and commitment to providing extraordinary and personalized care to older adults. Most recently, Jefferson Lansdale Hospital was recognized as an age-friendly health system committed to care excellence. Jefferson Lansdale Hospital's emergency department also recently received recognition as a level 3 geriatric emergency department. Well, thank you so much for submitting your questions in advance of tonight. And the questions that you will hear me asking the panelists tonight are all submitted right from when you registered for this webinar. If you have any questions throughout our discussion, for those joining us on your computer or tablet, at the bottom of your screen, you should see an icon that says Q&A. Well, we'll do our very best to get to as many questions as possible, but may not be able to answer all of them during this virtual event. And due to hospital university guidelines and privacy, we are unable to comment on specific cases. Likewise, if you're experiencing any symptoms that may require immediate medical attention, please consult a medical professional. Finally, don't worry, we've taken the liberty of muting everyone's line to eliminate any background noise, so feel free to move around and get comfortable. So with that, I would love to introduce our experts for the evening, starting with Dr. Natalia Demantovich, Geriatric Medical Director at Jefferson Lansdale Hospital, Dr. Jamie Swanson, Primary Care Physician, Geriatric Medicine, Jefferson Abington Hospital, and Carol Nigro, Geriatric Nurse Navigator at Jefferson Lansdale Hospital. Well, again, thank you for joining us this evening. And let's go ahead and just jump right into the questions. Starting with question number 1, Dr. Demantovich, I'll turn to you. Can you talk a little bit about what age-friendly care is and what practices are in place, as well as feel free to introduce yourself to our audience. And if you want to unmute yourself, that's always something we tend to forget, I know.
I'm so sorry about that.
Perfect.
Yeah. Good evening. My name is Natalia Demantovich, and I'm a medical director of age-friendly program at Lansdale Hospital and attending geriatrician at 2 continued care retirement communities, Folkways at Gwinnett and the Hill at Whitemarsh. Just a little bit about myself. I graduated from medical school in Ukraine in 2002 and completed residency in internal medicine and geriatrics, fellowship in geriatrics at Abington Jefferson Health in 2011. I've been with Abington and now Lansdale Jefferson Health for more than 12 years now. So we'll talk about what age-friendly is. I want to give you a little bit of background. So John Hartford Foundation is a private US-based philanthropy whose mission is to improve care to older adults, and it was founded in 1929. On the other hand, there is Institute for Healthcare Improvement. It's also a private nonprofit organization with goal to improve healthcare worldwide by providing tools and resources to healthcare workers. So, but in 2019, those two foundations kind of united and decided to improve care for older adults worldwide, and they came with an age-friendly health system. So it's the initiative of both healthcare, John Hartford Foundation and the Institute for Healthcare Improvement. And they define age-friendly health system. The main aim is to follow essential set of evidence-based practices, cause no harm, and align care with what matters to our patients, to older adults. So they define also as becoming age-friendly It involves reliably providing set of those 4 evidence-based elements. They look at their different meta-analysis and research and define those 4 M's that would perfectly align the care and reflect what elderly patient may need. And those 4 M's are what matters: mobility, mentation, and medications. So I'll talk a little bit about each of them, in generally what it is, and what we do at Lansdale Hospital to make sure we incorporate those 4 M's into daily care as when the patient is inpatient. So first and most important is what matters. For what matters, we care providers and caregivers should know what matters to the patient for specific health outcome goals and care preferences, but most importantly, to incorporate what matters into their treatment plan. So at Lansdale Hospital, we started, since the program was developed, we are asking patients who are being admitted to the hospital what matters to them the most. I mean, there are different questions that we can use. What's most important to you? What do you value the most? But they all targeted to figure out what's most important for patient and try to align care around that. So nursing staff is asking patients, physicians asking patients. We are documenting on Epic, and it's visible to any care provider team. And we also update our whiteboards in a room, so patient also feels he communicates his needs and his wishes, and incorporate those wishes and needs in patient's care. So second element is mobility, and the goal is to maintain patients mobile and functional for as long as we can, but also prevent and treat any complications of being immobile, complications of immobility. So what we do at Lansdale Hospital, daily nursing staff evaluate patients for the highest level of mobility. They're trying to get patients out of bed and see what they can do safely to make sure they keep them moving to avoid the conditioning. We have physical therapy and occupational therapy consults while patients are inpatient, who made recommendations on level of discharge patient for safety and for strength work. And also we also started health program, which is a hospital elder program in the hospital. And we are training our volunteers, planning to train volunteers in the next few weeks to have safely ambulating patients who have scores that safe enough to not to have assisted devices and mobile, who came to the hospital in a good physical health. So all those measures will help our patients to avoid the conditioning, stay mobile, and avoid the complications and risk of falls. The third and one very important M's is medication. So the goal is optimize the medication list and try to reduce harm that possibly some medication interactions or possible side effects might cause patient, and also focus on how medications are affecting mobility piece and mentation and what matters to patient, because sometimes patient doesn't want to take medication that we feel strongly that he might benefit. So we have to respect the wishes and discuss what matters and effects of, taking or not taking the medications. So at Lansdale Hospital, we have medical staff, our doctors have monthly education on, reviewing high-risk medication, discussing antibiotics and antipsychotics and benzodiazepine and other medication that might cause harm. We are practicing de-prescribing. So every time we see patients, we kind of go through the list and say, okay, does he really need this medication? What is this medication for? And that includes not only prescribed medications, but also medication over the counter, supplements, vitamins, herbal supplements. There's also Beer's list, Beer's criteria that list all of the medication that potentially can cause harm. This is not a medication that you should never use in geriatric population. There are exclusion, but you have to be aware of, okay, there is possible interaction. Maybe there is alternative, and consider what would be the best to use in a certain scenario. So this Beer's list just recently was incorporated in Epic system, in our electronic medical system. And every time we are trying as a providers to either order or review medication, the alert will pop up and tell us that, pay attention, there is a possibility of side effects, which really helps with, being more aware of what we're prescribing. And sometimes some interactions that, on a smaller percentage, but still might happening. So it's always good to be reminded and pay attention to that. And sometimes patients who come with very large with polypharmacy with the medication list, geriatric consult is available to look at the polypharmacy and review medication with patients and family and provider. And the last one of the 4 M's is mentation. So mentation itself has underneath 3 D's: depression, delirium, and dementia. So the goal of mentation is to identify those 3 conditions and across all care settings, and look at the medication to make sure medication does not cause those issues, and treat and support family with that. Since we have our emergency department is accredited as level 3 geriatrics, we have delirium screening on patients who are being admitted through Lansdale emergency department. So nursing staff screens patients, and if the patients are positive, this being communicated with the nurses on the floor, and they proceed with a more thorough evaluation. While a patient being in a hospital, nursing staff daily evaluate them for any signs of delirium with the version of the screening tool. They also being screened in the emergency room and on the floor for depression, with this very sensitive short and long version of screening tools. At times, not always, but at times there is appropriate to evaluate patient with the screen patient for possible dementia. I'll have to mention that it's being in hospital and screening for dementia is not the best option because, there are too many factors that can affect cognitive performance, but in some circumstances we can do that. And we referred patients to outpatient psychiatry, neurology, and geriatric assessment center for more thorough evaluation after patient returns to the baseline. Also, patient who comes into the Lansdale Hospital are being screened by risk factors that me and Carol, who is a geriatric nurse navigator, established, and she sees patients who are high risk for complications or high risk for readmissions. So out of all patients who were admitted 65 plus, we're trying first to target those patients who possibly might have complications. When there is a geriatric consult, my consult is being formatted in 4M framework. So to help hospitalists and outpatient care providers to kind of try to incorporate the 4Ms into their care more easily. And lastly, on discharge, all those recommendations are given to patients as well as resources. And we make recommendation for safe discharge and recommend levels of care that patient might benefit from. For example, home, independent, home with help, assisted living, or skilled nursing facility. And that's about it. Just wanted to mention that Lansdale Hospital was recognized in September of this year. And Abington Hospital has been recognized, I think, for a couple of years now. Thank you.
Thank you, and very exciting to hear. Thanks so much for detailing that for us, and really interesting to see those proactive practices put in place for patients. So thank you. All right, let's continue with our discussion. Dr. Swanson, we'll turn to you for question number 2. What services are available to patients and families in age-friendly care? And again, feel free to introduce yourself as well.
My name is Jamie Swanson. I am a primary care doctor at Abington Adult Medical Associates, which is in the Levy building right across from Abington Hospital. I'm originally from this area. My family has been coming to Abington Hospital for decades. So it's really nice to practice in a place where I grew up. I started doing geriatrics as an internal medicine doctor, and I became medical director of a transitional care unit at a nursing home. And I liked it so much that in 2020, I came back to Abington and did a geriatrics fellowship. Then after my fellowship, I joined the practice and started not just seeing patients in the office, but also in the hospital with the internal medicine residents and our geriatric fellows. So one of my favorite programs is one that I work with every single week, and that's our Geriatric Assessment Center. And this is basically a service for a comprehensive outpatient evaluation of older adults. And probably the most common reason that people get referred to the GAC is because there's concern about memory loss or dementia. But I have to say, after 2 years of doing these assessments, I have never had one that's been the same twice. Sometimes people come in and they think their mom or dad, and usually when I say these visits, there's usually a patient and there's always a caregiver with them. And there's me and our social worker, Barbara, and we sit down as a group and we take a really complicated, long history, probably ask you questions like where you went to high school and what your job was, and do you go to church or synagogue over the weekend? Like, what kind of clubs are you in? So it's way more detailed than probably any visit you've ever had with a physician. And we try to figure out, hone in on the problem that brought you in today, and then really try to figure out what we can do to help it and give you some good concrete suggestions you can take back to your own primary care doctor or your other specialists. So the visits are about an hour. And it could turn out that your mom doesn't have dementia. Maybe she's depressed, or your mom's real issue is mom or dad is having memory problems, but she needs help in the home. And you really need to talk to a social worker about what services are available. And, sometimes we find medication interactions. It's just amazing. And the 4 M's that Natalia so beautifully described is really what we focus on in the visit. So it really is a way that the 4 M's come to life. Often after those visits, one of the biggest recommendations we make is to send some patients to the Memory Fitness Center. And this is at Lansdale and Warminster campus. And this I describe as physical therapy for the brain. So it's like a half-day program. You can come as often or as much or as little as infrequently as you want. It can be just an occasional thing. But they do word games, they work on physical activity, they talk. And the nice part about it's a very warm and supportive environment, because that every single patient at the Memory Fitness Center has some kind of memory issue. So it's a place where it's okay if you make mistakes, because everybody there is really in the same boat and they understand, why you're there and what the purpose is. There's also a really, really popular adult day program at Lansdale Hospital, which I heard is actually almost at capacity or potentially has a waiting list. But this is great because it's actually at the hospital and it's affiliated with the hospital. And, this is a great alternative for older adults who maybe are alone during the day, and you're not crazy about potentially having caregivers come in the home. So adult day programs are perfect ways for people to get some support and some camaraderie and hang out with other older adults. And once again, it's in a setting that's very supportive because it's all older adults. Other programs that I find really cool, the HELP program is at Abington and Lansdale Hospital. And this is volunteers that really come and they visit patients who have delirium in the hospital. Often they can fill in some gaps in their care. I've seen them provide reading glasses. I've seen them come in and bring newspapers, and sometimes they just sit and talk with patients. And the other really great thing about the HELP program is certain times of the year, like especially the summer, it's staffed by pre-med and pre-nursing students and other volunteers throughout the year. So I don't know, I'm sure many of the people listening either are an older adult or the adult child of an older adult, and you probably also have college-age students. I would love for them to look into this program because it's a great way for them to spend their summer break. And it means so much to the patients that we take care of in the hospital, because I would love to sit and talk with the patients, but unfortunately I can't always. So to know that there's like a bright-eyed, bushy-tailed, like high school, it's usually college student who's going to go in and talk to them and make sure they have their reading glasses and they read the paper. It just makes me feel so nice. And the volunteers get so much out of this program as well. So they're probably my top 4. There's many more which are on the website, but I hope at least you guys remember these 4.
Certainly, that was really helpful. And just going back to the Memory Fitness Center for a second, I liked how you described it as a physical therapy for the brain. So yeah, thank you for detailing that. Very helpful. All right. Well, let's go to question number 3, continue the conversation. Carol, we'll turn to you as a nurse navigator. How can someone be proactive and an informed healthcare advocate for aging parents who maybe they do not live close by? And again, of course, feel free to introduce yourself.
Well, good evening, everyone, and welcome to the program. I'm Carol Nigro, and I'm a nurse at Jefferson Lansdale Hospital. I graduated from Holy Family University with my bachelor's degree, and I received my master's degree from Drexel University. I've been a nurse for over 35 years in many different areas of the hospital, including leadership positions and over 20 years in our Jefferson Home Care Department. This past year, I started to work in my current position, which is the nurse navigator position at Lansdale Hospital. And this past year, I obtained my geriatric certification because I love working with geriatric patients. So to answer the first question, when you don't live close by, of course, that's very hard on anybody who has an elderly parent or family member. One of the first things that you really want to do is try and get a support network together for people that do live around your family member, whether it be a neighbor or, you know, a private pay person that can go and check on them. And you want to make sure that you have their phone numbers to check on them, you know, whether they're checking on your family member like once a day or every day, every other day or once a week, and then make sure they have your number as well, because it's really important, if they're noticing something in the house or with your family member, that they can call you to let you know what's going on. Another good thing to do is to have like pertinent medical information of like who your family members, family physicians are, or any of their specialists. Have those phone numbers available in case you need to contact them for anything that's going on with them. And also, I know this sounds a little weird, but, you know, having like numbers of the utility companies in the area of where they are, just in case for some reason, you know, something like their electric goes out or whatever, you can contact the utility company just so that they would have, you know, peace of mind that somebody else has that information. Something else to have in together is, you know, in case there's a weather crisis where their heat goes off or the air conditioning goes off, have an emergency plan available for your family member so that they would know where they could go if something should happen like that. And then you would have peace of mind as well, that they're being, you know, cared for. How about, you know, always having those video phone calls? I know we all have those iPhones or Androids, and those video phone calls, they're always so important just to keep connected with them. It helps both of you, both emotionally and, you know, physically, knowing that, you know, that they're doing okay. And if you are able to get to see them, you know, and when you're there, you know, if you're out of state or whatever, and you come to visit them, try and schedule those medical appointments when you're there. So that way you can get to meet the doctor and ask any questions. And if you're not able to be there for those special medical appointments, you know, maybe they could do a video phone call for you. And other things that you can do while you're there, you want to go on a car ride with that person if they're still driving. You know, are they able to move their foot from the gas to the brake, you know, in an adequate amount of time? Are they using those turn signals? Are they staying within the lines of the, you know, of the road? They're all important things to be watching out for. Thinking about where they're getting their groceries. Are they going to the store themselves? Are they ordering online? You know, how are they getting their food? And how are they cooking their food? Are they using an electric stove or a gas stove? Do they just have the ability to use a microwave? And back to the stoves, make sure that they're not using their electric or gas stove as a heating element for their kitchen or the rest of their house, because that could be really dangerous. How are they walking around in their house? Are they using their cane and their walker properly? Are there any area rugs that you need to move around so that they don't have any tripping hazards? Or any electric cords that could also be tripping hazards? Do you need to secure them, so that they don't fall? Because falling, is a big thing with elderly. How are they bathing? Are they, bathing on a regular basis? People that don't bathe as much as they should, tend to have, get more infections. So you want to make sure that they're, taking care of their personal needs. Are they able to dress themselves? Are they, do they have trouble with their shoes? Are they able to tie their shoes, or do you need to start buying them some shoes with some Velcro on them? Are they able to do buttons on their shirts or zippers? They're all different things that you want to think about while you're there. Also, who's doing their laundry? Most of the laundry things in people's houses are in the basement. Are they able to, carry their laundry down? And then are they able to get it into the washer and then into the dryer and then carry it back up? They're all things that you really want to be looking at while you're there. And then the last thing that I would just wanted to touch base on was medications. Are they taking their medications as they're prescribed, or are they cutting them in half because they don't, they feel that they don't need them as much as they, are prescribed? Are they filling a pill planner, or does someone need to fill that pill planner for them? Or a pharmacist, do they need to have go to a pharmacy and have them start doing what they call blister packs, where all the medications are in one little bubble and they just have to open it when it's time for them to eat or to take their medicine? So there are all things that really, for people that live far away, they're just different things that you might want to look into.
Okay. Thank you. Certainly some important considerations to keep in mind. So very helpful to hear. Thank you for detailing that out for us. All right, Dr. Domantovich, we will turn to you for our next question. And a big question here, when to start seeing a geriatric physician. So do you have any recommendations on when someone should start seeing a geriatric physician, and at what age is someone considered geriatric?
Okay, thank you. So a geriatrician is an internal medicine or family medicine trained physician who has received additional training. Usually it's 1 year. Some programs have 2-year additional training, one dedicated to research. They're specifically treating adults age 65 and older. And common conditions that occurs at this age, such as memory loss, mood disorders, Parkinson's disease, urinary incontinence, falls, ambulatory dysfunctions, arthritis, and other neurological conditions. So, as we age, the number of medical problems increases, number of medications we take, as I mentioned, increases, and the possibility of drug interactions are also increasing. So, a lot of people might think, well, it's the same kind of physician as like my primary, they completed residency and training in internal medicine and family medicine, and my primary care physician sees all ages. I mean, that's right, but I have to tell you, after 9 years of practicing geriatrics, I had a chance to practice internal medicine in a busy office, Abington Jefferson, primary care office. And, by the time it goes, when you see all different patient population, you tend to not to forget, but really concentrate on the main issues. What we have a preference in geriatrics is we focus our care on those we know what's more common as you get older. We know what early signs and warning signs of conditions that might be, take a patient's life surprisingly. Like we know some signs when memory starts declining, or early signs of depression. And when they intervene, early in the disease, there is still higher chance to have a better, quality of life and being more highly functioning at that age, until rather than you wait until really symptoms are all, full blown, and you really, it's too late to make a difference because of the complexity of the disease and because of the, how this disease affects our body and, specifically our brain. So 65 and older usually is a cutoff for geriatrics. But there is, I have patients who are 60-year-old, or 58, but they are really proactive. They have some health conditions and they want to start seeing geriatrics and early age healthy, or, do whatever they can to prevent rapid decline. But overall, it's 65. We recommend that if someone has not a lot of healthcare problems, staying active and feeling, 65 is just the number. They can continue with the primary care physician, of course, but we would recommend them to come to a place like Geriatric Assessment Center, like Dr. Swanson mentioned, at least once a year. Maybe if they remain highly functioning, can be every 2 years. So at that time, geriatrician will evaluate their mobility, memory, and mood, and define what matters, and kind of shape up their care and communicate with the primary care physician. But patients who have complex medical illnesses, or any age, and especially 65 and older, I think would benefit from seeing geriatrician, as early as they can. And it's also important to discuss this with your primary care physician. Have comfortable your primary care physician feels managing medications, let's say for depression or for dementia. Would he rather have a consultation done from other subspecialties, or just to switch to geriatrician? And primary care physician will give you that recommendation based on their understanding of your complexity.
Okay, thank you so much for detailing that for us. We appreciate it. All right, Dr. Swanson, we'll turn to you. Now let's talk a little bit about expectations. What can patients and families expect on their first visit if they are to go to a geriatric physician?
Well, I think the best part is geriatricians are often given a little bit more time compared to our average physician. I know that's a complaint I hear a lot, that I love my doctor, but my doctor is so busy and the visits feel rushed. It's really a big problem, for everybody. So I know when I have my first visit, I get at least 40 minutes. Sometimes I even get an hour, depending on what I think we need to discuss. And I really do go back to the 4 M's. I hope you guys aren't sick of hearing about the 4 M's already. So absolutely, the first thing I am going to do is go over your medications. So hopefully you brought the medications, or you brought a list, or you brought a family member who has a list. And, it's hard. The words medications are hard to pronounce. They have 2 names, a brand name and a generic name. Then there's some people take supplements, which often supplements can have ingredients like Benadryl that can actually be harmful for older adults. So we find all kinds of information out when we go through the medications. Often patients will finally confess and say, I was actually supposed to take that medication, like metformin, for example. It often can be dosed twice a day, but like a lot of people forget to take that PM dose with dinner. So, I need to know that. And I want to make sure people feel comfortable telling me, like, just be honest with me. There's no judgment ever. Because I find out all kinds of useful information. Generally, at some point, we're going to check your gait. Like, we'll actually make you get up, walk across the room, sometimes down the floor and come back. Are you using a walker or a cane? You probably should be using a walker or a cane, or are you completely fine? So one thing you also want to do is make sure you bring any assist devices with you so we can actually see how you move. Next, as I'm talking and asking questions, like I said, sometimes geriatrics doctors are going to ask questions that no one's asked you before, like, where did you go to high school? What kind of work do you do? What are your hobbies? And sometimes people like, tell me about your grandchildren. You know, what did you do over Thanksgiving? Sometimes you think I'm just being nice, but actually part of me asking these questions is I want to see if you can remember what happened over Thanksgiving. It wasn't that long ago. Do you know the names of your grandchildren? You know, can you explain what medical conditions you have? And that's how I determine whether or not you're someone that might have some cognitive issues that I have to delve into deeper. And I would say that every geriatrics doctor is going to be pretty skilled at giving cognitive tests. There's like dozens. There's so many different cognitive tests. I could talk about that for an hour itself. Some are really quick, like 5 minutes. Some take 20 minutes. Some can take, you go to a psychologist, you could do cognitive testing for 2 hours. Obviously, we're not going to do 2 hours worth of cognitive testing on a first visit, but often just by asking questions and talking, I can figure out, like, if I'm concerned, maybe I should do that 5-minute test just to get started and see if you need to have further evaluation at a subsequent visit. And then the last thing, the thing I'm also very, very passionate about is this what matters most idea. So I started out working in hospital medicine, and, you know, people come into the hospital, they're not at their best, right? They're often sick. That's why they're in the hospital. And I would ask people, like, we have to ask this question: what's your code status? And you know, when I started 12 years ago, a lot of people didn't know what I was talking about. And, you know, the hospital emergency room is the absolute worst place to have that discussion because, like I said, you're sick, you're upset, you're nervous, and you don't really want to make decisions that are serious when you're not at your best and you're not thinking clearly. So I'm very, very committed to making sure every one of my patients has what's called a code status in the computer. And also, you know, generally, how do you expect to age? Are you someone who's maybe looking to age in place at your house? Do you live with family? Are you looking to move into a facility? I want to know about that. And then, you know, the other thing is I want to have an emergency contact. So often, a lot of my patients, I don't know what percentage, maybe like a third to a half, bring their family members with them. And that's great because then I actually get to meet the emergency contact in person. So at least we've been seeing each other face to face. But some of the patients are independent and driving and healthy and vibrant, and they don't travel everywhere with their adult children or their neighbor or their spouse. So, you know, I at least need to know the phone number in case there was ever an emergency. And, you know, an emergency contact could be someone like a neighbor, it could be a relative. You know, it's something we have to have straightened out in the chart. And I hope that we never have to use it, but at least I know at that visit, I've got all like the hard questions out of the way. And then of course you can focus on whatever the real issue. There's usually some complaint. We call it our chief complaint. Like most people come to the doctor with some particular burning question that needs to be answered. So hopefully if we get through all the other things, we'll still have time to answer those questions too. And now when you come in for subsequent visits, you know, if you had a really great first visit and you were able to ask all these questions and really learn a lot about you, you know, it's not going to be an hour every time you come. You can do quicker visits as follow-ups. But the other, you know, thing with medicine is it's unpredictable. And sometimes patients need a little bit more time. And, you know, I think that when your doctor is really confident and experienced in dealing with older adults, you're able to be adaptable and sometimes give that person the extra 5 minutes that they need to get all their questions answered or deal with the problem at hand. So hopefully you at least get 90% of that at your next geriatrics visit. Or, you know, sometimes if there's a lot going on, I might say, you know what, this is a lot for today, but I'll have you come back in like 4 weeks and we'll tackle like the next 4 problems. So hopefully that answers the question.
Absolutely. And it sounds like a very productive visit, I would say.
Good. Should be.
Yeah. hoping that at the end of this, everyone knows the 4 M's because that is a recurring theme here. So thank you. All right, Carol, we'll turn to you for the next question. And just a quick note, I see a few live questions coming in, so thank you so much. And feel free to keep submitting them as any thoughts pop in your mind during our discussion tonight. We'll get to them at the end of this. But for now, Carol, we have a question for you. You mentioned earlier just the importance of connection. So are there any community resources for elders to get involved in, both in-person and virtual options as well?
So for right now, I mean, a lot of the ones right now are in person. It's very difficult to find some virtual things, especially when you want to keep mentally and physically active. Mentally, you want to get out there and, interact with people in the community and everything. Obviously, if you're sick, you don't want to be doing that, but we do want you to, keep physically active. And, there's different, to keep mentally active, you can go to different book clubs, either with family members, like where you read a book and then you have a discussion about it. Sometimes they can get pretty intense with those book clubs. I've seen them in action. And if you don't want to do a book club and you just want to, read your newspaper to keep up on current events, that's always really good to do to keep yourself, mentally intact. Going to those bingo games, many of the firehouses have bingo games, or, just getting together with some friends to do some bridge or Scrabble games. They're all great ways to keep mentally active. For physically active, you can go to the gym, any gym. There's all different types of gyms out there. They all cost different, amounts of money. It all depends, but what they're recommending for people over the age of 65 is 30 minutes for 5 times a week of aerobic exercise, and then 75 minutes of vigorous exercise a week. Really, it's not that much, and it's great to, go to these different gyms and you're still interacting with other people. Also, muscle strengthening. They don't recommend going over 5 pounds, which for some people might be very, a light amount, but for others, it's 5 pounds might be too much. But they're recommending no more than 5 pounds, 15 minutes, 3 times a week for that. And articles that I've read recently indicate that both aerobic exercise and strengthening exercise can actually increase your cognitive function. So that's a no-win right there. Many of the Ys out there have different classes for seniors. There's the chair yoga that people can do that aren't very good at ambulating. So that's always a good one to go to. Water aerobic therapy. Many of the Ys obviously have swimming pools, and that's great for people that have arthritis. Tai Chi, which I personally have never witnessed, but I have read that Tai Chi is great for Parkinson's patients. That helps with balance and flexibility and endurance. And then that good old walking, getting outside or going around a track inside, at the Y, that's a great way to get exercise. And many of the 55 and older communities that many of the elderly have been moving into, they all have clubhouses, where they have a variety of activities that you can go to. They go on different trips, or they actually do bingo, things like that. Going to senior centers, many of them have different activities that you can go to. And, just volunteering, at your local church or school or senior center, or actually even at Abington or Lansdale Hospital. We're always looking for volunteers for a variety of positions within the hospital. Abington and Lansdale, they have what they call an elder med program. You can get a newsletter twice a year, and it outlines a variety of activities that they have. They have healthcare screenings for like blood pressure or stroke risk, fall risk. They have different health fairs that you can go to. There's a lot of educational programs that this elder med program sponsors, and that could be educational programs on heart disease or diabetes prevention. And there's a variety of topics that they touch on throughout the year. And they also do some fun things. They go out on group trips. They have museum trips or sporting events. So that's always ways to keep yourself active out in the community. And Dr. Swanson, she did mention the Memory Fitness Center for those that have some memory issues, and the adult day services that she also mentioned. So there are all ways that you can, keep yourself busy while you're out in the community.
Absolutely. Certainly a number of ways, obviously from that long list. So thanks for walking us through that. All right, Dr. Demantovich, we will turn to you. Talking a little bit about vaccines now. Are there certain vaccines for those in geriatric care that you would recommend they should get?
Thank you. So I hope this answer will be a little bit shorter than the previous one. Definitely once a year of influenza vaccination is very, very important, because the mortality rate in geriatric is really high from influenza. So that's, I think, very important. And I would say number one, as well as now COVID vaccinations. So it is recommended for elderly to receive primary vaccination series, and then recommended to receive this bivalent boosters that is available and covers some of the Omicron variants that are circulating. There are always some patients asking question, can those two vaccines can be administered together? And there's no recommendation against not administering, but clinically, from just my colleagues' practice and my own practice, we like to separate those two shots by like a couple days, 5 to 7 days. And the reason for that is that some people might not react to, either influenza vaccination or COVID vaccination, depending on their immune system. But some people become, fatigued and sick just with the usual expected side effects from vaccination that tells us the immunity that works. So double shot might make them more weak, and we're just worried that that might increase risk of falls and confusion for patients who are frail and sensitive. Not for everyone. So COVID vaccination, influenza, then Shingrix vaccination. It's the vaccination to avoid zoster. And Shingrix vaccination is a 2 shots, a series of 2 vaccinations, but 1 month apart. Even though they received the zoster vaccine prior to that is one series of 1 shots, they still recommended to receive Shingrix because it's more effective. Then Tdap vaccination, the tetanus, usually given initial, vaccination and then booster every 10 years. There are some circumstances when patients who have injury might require extra booster, but overall, if there's no accidents, no problems, then it's every 10 years as a booster. And the last and not least is the pneumonia shot or pneumonia vaccine. Again, there is no clear-cut recommendation for all. So you have to look at your situation. You have to look at your, comorbidities. For someone who is just aging healthy and doesn't have a lot of healthcare problems, we recommend Prevnar and Pneumovax. And now there is a new vaccine, Prevnar 20, that can be substituted, 1 shot for the previous 2. But some patients who are frail, who has high risk factors, might require extra vaccination against pneumococcal. And I would just advise to discuss with your primary care physician and see if in which category you are.
Okay, thank you so much. We appreciate it. All right, Dr. Swanson, we'll turn back to you. Now we discuss a little bit about what the actual visit would look like, but can you suggest to patients and families how to go about choosing a geriatric physician?
Absolutely. This is a great question. Since I'm like a relatively newer PCP, I get a lot of patients who come to me who have not had great interactions sometimes with previous doctors. And I think listening to their stories, the number one qualification is you need a doctor who listens to you, because geriatrics is very specific to the patient. And just like I said in the geriatric assessment visits, no two are the same. I mean, honestly, no two office visits are the same either. You know what? 70-year-olds and 80-year-olds and 90-year-olds can be completely different, even if they're chronologically the same age. So the doctor has to hear what you're saying, because it's going to be different, and they have to really listen, not just look like they're listening, but take the time and actually hear what you're saying. The other complaint I hear a lot is about staff. You better like the staff, because the staff, sets up appointments, helps you navigate your visits. So a friendly staff, I think, is also really crucial. And, finally, I think it should be someone you're comfortable with, like going to a geriatrics doctor or a primary care doctor. It's a very personal, intimate kind of experience. Sometimes we hear a lot of people's, scariest moments about their relationships. And, it has to be someone that you're not nervous or uncomfortable being around. And then hopefully you and your doctor agree in kind of your approach to health. What I mean by approach, it's some of the things that Natalia talked about earlier. I love deprescribing. And one of my favorite things is taking people off medications that they probably don't need. I want to talk to you about how you see yourself aging. I like to talk, obviously. So, the patients hopefully like to talk with me as well. And that's why they keep coming back to me. But even if the patient and I have the same general approach to how they're going to age, doesn't mean we always have to agree. Because ultimately, I also want a doctor who respects my decisions, even if it's not what the doctor would. I mean, some of the greatest doctors, you never really know what their thoughts are, because they present the information in an unbiased way and allow you to really make the decision that's best for you. So those are my tips.
Great. Those are some helpful tips. So thank you for walking us through. All right, Carol, we will turn to you as our nurse navigator for the nurses attending this webinar. In what ways can nurses deliver better age-related care while geriatric patients are hospitalized?
That's a really good question. So one of the things that I like to do when I first walk into a patient's room, if their name is not on the whiteboard that, while they're an inpatient, because we do like to put, what name they like to be called by, I ask them, what, they might have like Kenneth on the board. And obviously most people don't like to be called, Kenneth. So I would ask them, what name do you want us to be calling you while you're here in the hospital? Sometimes, they want to be called by Miss Jones or, or a nickname. So we try and find out that the first thing when we walk into a patient's room. Another good thing to, look at is, are they using their assistive devices properly? And I mean, I'm talking about their glasses. Are their glasses clean? Are they on their face if they, need to wear them, for reading or, there are many people out there that wear glasses all the time. So are they actually wearing them when they should be? Are they wearing their hearing aids? Are the hearing aids plugged or charged? Are they turned on? And also their dentures. Do they have their dentures in? People, good nutrition is always very important. So we want to make sure that they're able to eat while they're in the hospital. And if they don't have their dentures in, then they're not going to be able to eat properly. We also want to ask about their current living situation. This is great for many of the social workers would be asking this. What type of house do they live in? Do they live in a modular house or a 2-story? Do they have a stair glide in the house? How many steps is it for them to enter? Or do they have a ramp to get into their house? Or do they live in an elevator building? So they're all important things to find out about. How are they getting their food? I think I'd mentioned this before. And how are they preparing that food? Do they get Meals on Wheels? Or is someone from their church providing them some food? How are they getting to appointments? Is a family member taking them? Is a neighbor taking them? Do they have to take public transportation, or do they have access to Transnet? Do they need to have an application put in for Transnet? Sometimes the Transnet applications take, a couple of weeks to go through before they can actually get, rides through that type of program. Do they have all their prescribed medications in the house? Are they using a med planner? Is someone filling that med planner? Are they using an assistive device? Do they use a wheelchair, a walker, a powered wheelchair? Excuse me. Are they using it in the home or outside the home? Also, just talking to the patients, many of them have so many stories, and you just really want to make sure that you listen to what they're saying to you. So thank you.
Absolutely. I think that's a really important point, that last point you just made. So thank you. All right, we just have a few more questions, and then we will turn to our live questions for the night. Dr. Demantowicz, we will turn to you. Can age-friendly care be accessed without a hospital stay? Is home care an option?
Sure. So as we all mentioned through this hour, the 4M care is not a specific program. It's a framework that we are trying to incorporate into healthcare on any level of care. So in-hospital stay, outpatient, skilled facility, assisted living, anywhere that patients receive care, we will try to, frame it into 4Ms. So of course it can be. I think one of the examples is that when patients are admitted to assisted living in a skilled facility, they being really thoroughly evaluated to see what's safe for them and what level of care they are. And at that time, they look through what matters and code status and 4Ms as a prior evaluation. So that's one example. Primary care physician, I'm sure that each of the care providers already have one or two more M's incorporated. They just didn't define as yet. But I think now knowing about 4Ms, it would be easier to communicate with the primary care. Okay, so what are you incorporating in my care? What, how else we can incorporate? There's only one thing I would like to mention that it wasn't mentioned yet. When one of the mentation, one of the M's, there is depression, delirium, and dementia, and very significant aspect of depression and concern that a lot of geriatricians have and primary care providers is that, suicidal thoughts that patient might have. So that's part of the 4M framework, to keep in mind that suicidal thoughts and rates in geriatrics are actually going up. And especially we see this with the COVID, lockdown and being withdrawn from the social life. So a few things to remember. Screening for suicidal risk is very important as part of the 4M care. And there is another 3Ds that patient might experience and that places them for higher risk of being suicidal. It's being depressed, being debilitated, and being, withdrawn from the social aspect. That kind of aligns with another question is that it's always important to tell your primary care physician and ask your patients if they own a firearm, because the elderly that age, they tend to own one, and that most commonly have people are used when they have a suicidal thought. So of course it can be accessed without a hospital stay. I think as with time we'll see this 4M kind of incorporate in all levels of care. Just to be aware, I think, and ask for it is the key.
Okay, thank you so much.
Yep.
And with all the live questions coming in, I think we can just turn to our live questions and start taking them before closing out the evening. So we will stay on past 8 o'clock, of course. Okay, so to start with it, I'm going to ask one of our live questions, and whoever wants to take it, feel free to jump in. But our first live question from the audience: is a geriatric assessment different than a Medicare wellness visit? And if anyone wants to hop in.
I can answer that one. No, they are different. So a Medicare wellness visit does have a lot of similarities, because you have to look at activities of daily living, you review a history, but there's specific Medicare wellness questions that often get asked. There's a format that we use. So every Medicare wellness visit across the United States is going to be similar. The advantage of the geriatric assessment is it's really tailored to what the individual needs are. And it does include a lot of the similar aspects, but generally geriatric assessment visits will have other health professionals available. Like I always do my visits with a social worker, which I don't when I do Medicare wellness visits in the office. A social worker isn't available, isn't always available, and is not included automatically as part of the visits. So if you've had a Medicare wellness visit, you can still have a geriatric assessment visit. And so Medicare wellness visits are done annually, and geriatric assessment visits can be done every 6 months.
Okay, thank you. Some helpful information there. All right, our next question: is it true that people metabolize medications differently past a certain age, and dosages may need to be adjusted? So Dr. Domintovich, if you want to hop in here.
Sure. So yeah, as we get older, the metabolism of medication would definitely being affected. So with age, we can expect that there is high risk of interaction, because not that liver and kidneys are not working to excrete, certain medication particles, but it just, the metabolism overall slows down. There is no cut age, and there is no specific adjustments needed to be done unless it's recommended by, the manufacturer. So usually they will say if there is a liver underlying problem or kidney problem or any other health problem, then we have to adjust the dose. There is no dosage needed to be adjusted just based on the age, because we don't have two patients that are, let's say, 70-year-old and they're exactly the same. So it has to be individualized approach, but we have to keep in mind that in geriatrics, when we prescribe medication, the rule is to start low and go slow. So, because some patients might be very sensitive and others might not respond, also based on their other medications. So I think if you remember, always start with the lowest dose, take time, and, taper up or down depending on the response.
Okay, start low, go slow. I like it. Thank you. All right, next question from the audience. This person would like to know, what are the benefits of being in an age-friendly hospital versus just a regular hospital? Does anyone have comments here?
I think Carol, I can answer the question as well, unless Carol wants to answer. I think it was covered by what Carol has presented already, and I have presented what we do at Lansdale Hospital, for example, that makes us different from hospitals that are not age-friendly or accredited. So the most importantly, the goal and how you benefit from being an age-friendly hospital is we train our staff, and we incorporate protocols and policies and pathways to recognize patients who are high risk of decline, having complications, high risk of readmission. We look at the patients who might be at risk for develop delirium, which is increased mortality overall. We have a tools to recognize delirium on early stages. We have health program, and we have geriatric nurse navigator who does visits and help patients to and physicians to optimize their care. We do consults, medical consults with recommendations to follow up, specifically tailored to geriatric care. So definitely there is benefit of coming to the hospital that is accredited and certified.
Okay, thank you. All right, this next person would like to know, can you comment on the rationale for ending pap smears and mammograms past a certain age?
I can answer that because I actually give a lecture about this to our geriatric fellows and residents. So there's a couple different medical organizations who investigate these kinds of questions and get expert panels together and come up with guidelines. So the biggest group is the U.S. Preventative Task Force. So I think the most important thing to think about in an older adult is, what is your current function? And what is and technically we're supposed to look at what's your estimated life expectancy. So that sounds very morbid. There's not like, I don't look up like the, Medicare chart they have or the Social Security chart. What I mean by that is, what kind of senior are you? Are you someone who's going to silver sneakers and still driving and vibrant and involved and wants to live to be 110? In a case like that, it might be worth doing more preventative tests because you're doing really well, as opposed to some older adults who say have a lot of chronic medical conditions, are not as ambulatory, maybe have cognitive issues. Then the question, the decisions become very personal. So if I'm dealing with a 65-year-old who is going to go hiking this weekend for a 10-mile hike, that person probably should be screened for certain conditions as long as they desire, because that's the last part. It's what they choose. And then I see another person who's the same age who has had a lot of heart attacks or has had cancer or has severe dementia. It's a discussion between me, the patient, if they're able to voice an opinion, and their family members. And often, when people are dealing with a lot of chronic conditions that are likely going to affect their life expectancy, it's called the shared decision-making model. And we often will say, what? No, we're not going to do a mammogram or a pap smear or go for that next colonoscopy, because what researchers have found is that sometimes more testing is not always a good thing, because you get a lot of false negatives. And, this is what the big discussion about mammograms are. Mammograms were only studied in adults up to their 70s. So when adults over 75 get mammograms, often it leads to there's abnormal findings, which leads to biopsies and extra testing. And that process is super stressful and really traumatic, and often, very nerve-wracking. And sometimes in a frail person who honestly may not live well into their 80s, like, was it really worth it? Once again, it comes down to the decision between you and the doctor. This person may say, I don't care how frail I am. I don't want to have breast cancer. I'm deathly afraid of it. I want to have the mammogram. I'm still going to, if they choose that after we discuss the risks and benefit in their particular scenario, I'm going to ultimately, we're going to come to a decision together. So that's where and the pap smears, thank goodness I'm not a gynecologist, because I feel like they change those recommendations often. And, I know at least I do send patients to my friendly neighborhood gynecologist if there's those kinds of questions. But, it's gotten very complicated because there's HPV testing and, whether or not you've had a hysterectomy and things like that. So I know if I can't answer the question, I'm going to have you see my local gynecologist. Hopefully that helps answer your question.
Absolutely. And sounds like an important discussion to be had. So thank you for outlining that for us. All right. Our next question, Carol, this question might be for you. Do you offer resources to help choose CCRCs or assisted living facilities?
We do have a list of different assisted living facilities within the, that our social workers and our case managers have. However, we always like to give a patient a choice. So we don't like to make that decision for them. So they would be provided like a list of facilities. We do not endorse any of them, but so it would be really up to the patient or the family member to make the decision which one that they would like to go to. And you also have to, some of the assisted livings, don't accept certain insurances either. So you have to think about that as well.
Okay, thank you. All right. We have just about 2 more live questions, and then we'll close out the evening for tonight. But one quick question here. Are older adults at higher risk for COVID? Should we still be following social limitations? For example, should I still not eat inside a restaurant? What can I do to protect myself while still socializing? And if anyone wants to jump in.
I can answer that question. So it's been what, 3rd year into COVID. We all know a little bit more about it and the transmission and the treatment. And luckily we have vaccinations available that really shown that, being fully vaccinated, but recommended, as I mentioned, vaccination and being boosted, it really decreases the chance of severe disease and illness. Yes, you can still get COVID, but if you are fully vaccinated, then your risk of having complications are not as high. It's much, much lower with vaccinations. And as also we learned that as COVID mutates, it has, it's not as severe as when it started. So it mutated in a weaker variant. So the key is to be vaccinated and be cautious. If I do not personally, I think we should all follow up CDC recommendations, but I don't feel personally that at this point, if you are fully vaccinated and you have no symptoms or in no contact with other patients who might have tested positive that you know of, limit yourself from being withdrawn from the society, because effect of that is, as I mentioned, tremendous on depression, cognitive decline, suicidal rates, and overall aging. So to answer, I think again, everyone is different. Make sure you're fully vaccinated, not only against COVID, but also up to date with all the vaccination, and especially influenza, that will prevent you from having severe disease. As long as you have enough symptoms and your, loved one or friends who are you meeting with, it's okay to ask, how are you feeling? All okay? Because if you're frail, you want to make sure, you're aware and your party is aware that they're at risk. And I think go ahead and socialize. If you feel safer wearing masks in a movie theater or not in a restaurant where you're eating, somewhere that you feel there is more people, a small environment, I think if that helps, I mean, definitely you can wear a mask to protect yourself, but by any means, if you're fully vaccinated, I would not limit any socializations.
Okay, thank you. Definitely an important question, and knowing just previously how we discussed the importance of connections. So thank you for that. All right, we will continue with, we actually received 1 more question. So we have a few more before we close out the evening. But a quick question about dealing with mobility issues. Any suggestions on dealing with mobility issues when you're limited because of using a walker?
I think that people often think the only option is physical therapy. And there's a lot of other options out there besides just a referral to physical therapy. Now, I do feel like I really often when I'm ordering physical therapy, I feel like the rules have gotten a little bit stricter. I really do have to document that there's been a functional decline. So, you go to the idea, I think people should think about physical therapy as a treatment, almost like a medication. So if you start physical therapy and you improve, you generally work towards meeting your goal, whatever your goals, the goal that you set for physical therapy, and you continue until you meet the goal. And then if you're doing physical therapy and you're unable to meet the goal and you fail to continue to show improvement, the physical therapy is not supposed to continue. And that's a really tricky thing for people to understand, because in the past, we could just continue to keep ordering physical therapy for many, many sessions, and that has changed. So I often now find myself, what do we do for people who may not qualify for physical therapy or who have completed physical therapy? If you have completed a session of physical therapy, you will often be given what's called a restoration program or a home exercise program. That's the hardest part. Everybody leaves rehab or the PT gym and they're doing really well. And then they go home and they're supposed to do leg lifts and arm exercises. And, we don't do it. I don't go to the gym the same way I did when I was like in my 20s, because I have other responsibilities and I get distracted and it's hard. So that's one option is having this home exercise. Other interesting things that I've heard about, there are sometimes trainers and exercise therapists who can be hired or available in the gym setting, like Silver Sneakers, or especially there's a lot of older adults around Abington Hospital, and I hear about different people who are out there. And I've also tried to get really creative with people. Do you have Netflix? Have you thought about yoga? Have you looked at your local library? Do they have any Tai Chi classes? Like Tai Chi is the most amazing exercise for older adults, and we don't talk about it enough. And it's great for balance, and it's great for flexibility. And it's been around for thousands of years. And I've never had anyone come into Abington after falling from Tai Chi. I haven't seen it yet. So it seems like to me that it's probably pretty safe. And, you just have to kind of think outside the box a little bit. Like, can you access your iPad or your laptop and, look online for resources or go through, but even if you want it old school, like in person, the libraries are starting to have events again. The other thing that's amazing is, the Willow Grove Mall opens at 9:00 in the morning and people still walk. I think there's more people walking in Willow Grove Mall for exercise than actually shopping in the stores. I always tell people, like, do you go to Target? Do you go to the supermarket? Like, have you been to the Giant? It's enormous. If you can walk through the Giant with a shopping cart, to me, that is a significant amount of exercise. And it's also really rewarding. I encourage people to use their step counters, either the ones on their cell phones, or you can buy a simple pedometer, and really set goals for yourself. Sometimes when we want to start an exercise program or a mobility program, it seems like overwhelming. Like, they have these articles like 10,000 steps a day. Now it's 7,000 steps a day. And you could check your iPhone and you're at like 2,000 steps a day. You're not going to go from 2,000 steps to 10,000 steps like in a week, right? You have to work up to it. So I always encourage people, if you're mostly in the house, try to go up a couple hundred per week, like maybe in 3 months, your goal is to get to 3,000. And, little stuff. I have this discussion with my husband all the time. Like, when you bend over to pick up the clothes on the floor, all those steps add up. When you carry the laundry basket upstairs for me, those steps count too. Now, some of you may not have the best balance. You can't carry the laundry basket, or you get dizzy when you bend over. But there's definitely ways. I've heard stories like people get up during the commercial break and they do a circle around their living room. So hopefully this is the kind of idea, if you talk with your doctor or your family and friends, you can come up and brainstorm with some of these inexpensive or free options and just start out. Like, the same thing with the medication, start out small and try to increase your activity in a stepwise fashion. And I guess I'll see you guys at Target walking with our shopping carts.
Small incremental goals. I like that. And I think also takeaway from the discussion tonight is that Tai Chi is the way to go. All right. Carol, quick question for you from one of our attendees. As a hospital patient, do we need to request to see the geriatric nurse navigator? How do we meet with them?
So no, you don't need to request. I get a list every day of all the patients that have been admitted to the hospital over the past 24 hours. And I will, go in and introduce myself, see if there's anything that they need. I will do a quick assessment, memory assessments just to see, where they're at. And so no, they don't need to have an assess or a request. We just automatically come and see you.
Okay, that sounds good. All right, and our last live question for the evening: how often should seniors see their doctor? If you don't have any chronic health conditions, how often is it necessary?
I can answer that question. And again, I'll say it all depends on your health. So if you're 65 to, let's say, 75, there's no, I'm just coming up with the ages, right? If you're overall healthy, a highly functional adult that is aging in good, meaning staying active, good nutrition, doesn't take a lot more than 3 to 5 medications, really compliant with care, you can see a physician, geriatrician, or your primary care every 6 months. If you're very healthy and you have no problems, you can do once a year. But it's recommended if you have multiple health problems or complex problems to follow up with a geriatrician or with primary care physician every 3 to 4 months if there is changes in acute changes in their medications or health, or maximum every 6 months. So all depends on your health. I think anywhere between 4 to 6 months for someone who has health issues, and for otherwise healthy, younger, older, there are circumstances that you can see once a year as well.
Okay, well, thank you so much. And thank you to everyone who submitted such wonderful live questions this discussion. I certainly learned a lot of information tonight. So thank you for your thoughtful questions. I do have one last question of my own before we close out the evening. And I would just love to know what your goals are for everyone listening in on this webinar. What would you like our viewers to take away from tonight? So Dr. Dementovich, we will start with you.
Okay, so as I've been saying for the last 1.5 hours, I think if the viewers can remember and learn about 4 M's, that would be, my goal and my expectation. It's so important to be advocate for your own care and having 4 M's incorporated in your care. Knowing about, again, 4 M's, say it again, medications, mobility, what matters, and mentation. And under mentation, we mean depression, dementia, and delirium. And also, talk to your family members about what matters to you the most. In case situation happens and you're not able to communicate, then at least they know. And anywhere you go, any level of care, ask, is 4M being incorporated in my care? And I think that's the key to receiving, evidence-based, high-quality care in elderly. Thank you.
Thank you so much. And Dr. Swanson, any takeaways from you?
Well, first, I'm really impressed that so many people logged in tonight. I think that's very cool that you spent this time with us. I have 2 big takeaways. First, I hope I gave you some ideas that you can make better use of your doctor's visits. Like, for example, make sure you know your medications or you bring a list with you. And then the second thing is, not only should your doctor know what your wishes are, your family should probably know what your wishes are as well. We didn't really delve into that too much with what matters most. But as part of that discussion, one of the questions I always ask is, do your kids or your husband or your spouse or your whatever, whoever it is, whoever that person is, do they know, what your wishes are? And I think if you keep those 2 things in mind, all of us are going to have a very productive, very helpful doctor's visits. So thank you guys for listening tonight.
Thank you. All right. And Carol, to close us out.
Mine is very short and sweet. I think it's very stressful to have a loved one in the hospital, especially if they're an elderly person. So be prepared, have those lists together, bring in their equipment that they need so that they can function in the hospital. And, also take care of yourself, because you can't take care of your elderly relative if you're not taking care of yourself.
Absolutely. Well, thank you so much, Dr. Dementovich, Dr. Swanson, and Carol for your time this evening. Certainly a lot of great information was shared about age-friendly care. And again, thank you all so much for attending tonight and submitting such wonderful and thought-provoking questions. We appreciate it. We will be posting an event survey, so you can let us know your thoughts. Was this helpful? Are there any other specialties you would like to hear about? Your feedback will bring more virtual events like this to you, the patients. If you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, please fill out the last question in the event survey. And be sure to visit jeffersonhealth.org to stay up to date on upcoming classes, events, and webinars just like this one. We have a heart and cancer focused webinar coming up in February, and we'll post that information in just a moment. A recording of this event will also be sent to you so you can rewatch. And if you'd like to view other Wellness Webinar Series events, please visit our Jefferson Health YouTube channel. There is everything from back and neck pain to robotic surgery to planning for pregnancy and much more. If there is anything anyone here at Jefferson can do for you in this time of need, please reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. Have a wonderful night.